We started, actually, I started the first specialized clinic in orthopedics for congenital abnormalities. The first one was in Tunisia, the Department of Pediatric Orthopaedics, with a colleague who was very enthusiastic spine surgeon, pediatric spine surgeon, Professor Margaret Sham, one of the best in North Africa. And our experience was successful. Long before I go to Tunisia, I established the center. Most of the patients were sent the radiographs, the MRI, the CTs to Nicaire Hospital in Paris for diagnosis. When I started the work with them, we stopped this. I published the first book in 1993 about 28 families with different forms of congenital malformations. And every family was studied thoroughly. My experience then expanded to Austria when I met Professor Franziger in 2002, 2003 too. And he is one of the best pediatric orthopedic surgeons in reconstruction. And his work was compatible with my experience. So he established another clinic in Orthopedic Hospital of Speising in 2003. And before I go to Vienna, most of the patients' documentation were sent to Freiburg University Skeletal Dysplasia and Syndromic Association Center run by Professor Spranger. When I started the work there, we stopped sending any patient, any documentation. And we were successful. In a short period of time, we published about 180 papers. And I got the opportunity to contribute in 4 internationally breakthrough syndromes. And I got the Al Kaissi syndrome. This is what they have of the colleagues in Tunisia, Austria. 2010, we established another center in St. Petersburg, in Russia, and was successful. I was awarded the DSC, was awarded the Golden Medal, and it was a very good experience to me. And then we established another center in Dagestan, with the Republic of Russia. It was also successful, and of course, after the war, all these setbacks. Circumstances, we stopped, but still working as an expert with the Russians and Austrian in different parts of the world. I'm seeing patients almost every day on a daily basis. So, sorry for this long introduction, just to give you an idea. So, etiological diagnosis of bone disorders, I think, is the cornerstone in any long-term management of patients with chronic bone diseases, because we have 2 types. It's either acute presentation of children or adults, or we have chronic. The chronic one, which is frequent admission to the hospital, it requires us to really understand and investigate the issue, these patients. Genetics is a very important part in human lives. Genetics and environmental factors across 50-50. And as you see, these figures actually that was taken was published in the USA 40 years ago. I have no idea about the new, but in 1982, Professor Eberman from England did a comprehensive study all over UK. And he found out that 30% of the pediatric admissions in hospitals are due to genetically determined disorders. And then when I started working in Tunisia and then Austria and then St. Petersburg, there was widespread discussions with the colleagues. What is the percentage of patients we see with congenital malformations? Not necessarily syndromic. With syndromic, I mean syndromic, which is dysmorphic facial features like the Ilizarov 21 or chondroplastic. No, this is very well known. It's rare, but it's the most frequent, the frequent type, which is the mild and the moderate types, which present itself on step by step until the age of puberty. After puberty, we have patients with required hip joint replacement, having idiopathic, what they call idiopathic scoliosis, but we prove this is wrong, or idiopathic valgum. So etiology understanding is the cornerstone. Since 1951, there were efforts by Professor Fairbairn and Ben Davies here in England to give an outline for the skeletally dysplastic disorders and compare it with the normal patients. So, the diverse presentation of children, of course, adults and syndromic or heritable bone disorders, connective tissue disorders, or whatsoever. We have neonatal lethality, which is most of the time is not investigated. Mild growth retardation easily missed, but it manifests itself after puberty. Either pubertal stage when they develop, like they call it idiopathic, or the severe malformation complex that we can diagnose it soon. So we have two parts, the phenotype and genotype. Which is the baseline too? Is the phenotype. The phenotype, that's what when we analyze every patient in accordance with minor or major malformations. For example, cleft lip is a major malformation. Oligodactyly is major. Cleft foot is a major. Congenital scoliosis is a major malformation. So when we have one major, two minor malformations, this is a syndrome. Sometimes patients manifest just one, and we should investigate the other family members to combine mathematics, to combine what we elicited. So family history is a very important part. It's 50%, 60% of the diagnosis depends on family history, especially when parents are openly minded and give the information that is needed without any, obstacles. Two major categories of congenital malformations: recognizable syndrome. This is rare, like achondroplasia, trisomy 21. It can be recognized at birth or soon after because of a massive skeletal dysplastic disorder in these children. But the real challenge is the normally looking kids of adults, but when we investigate them radiologically or CT scan, we found enormous constellation of malformations. Our main subject today is torticollis, and as you know, torticollis is not uncommon in orthopedic practice. This is the definition of torticollis, which I assume most of you know now. So the classical classification of torticollis: congenital non-painful, congenital muscular. But here is the problem: abnormal craniofacial contour, like facial asymmetry. Facial asymmetry, when we see a child with torticollis and facial asymmetry, this is not muscular. This is syndromic until proved otherwise. We cannot proceed with any medical line of treatment unless we understand carefully. As I say, the clinical phenotype and analyzing the phenotype of these patients, studying the craniofacial contour, the limbs, the height, the growth, all these factors should be analyzed. So these are the keywords of mine. We start with some examples from my personal experience with patients. First patient is congenital torticollis as part of a major spine malformation complex and part of syndromic association in a family. Of course, when we diagnose a case proven, we also extend our investigations to see the others, because there is minimum involvement. It never can be in one, never. And in my previous decades of experience, I never saw this. Sporadic is very rare. Sporadic involvement of skeletal malformation or syndromic association, sporadic is very rare. It's mostly irritable. The first patient is a 16-year-old boy presented with marfanoid. Marfanoid, the name of marfan, which is tall stature, ligamentous hyperlaxity, arachnodactyly, dislocation of the lens, cardiac problems, dissecting aneurysm. So we call marfanoid when we have a thin, long limbs, not necessarily with arachnodactyly or other. So, but it looks like marfan, but not necessarily tall. We have patients short stature, but they are marfanoid. So, as you see, is normally looking intelligent, but have problems in his early life, in his developmental motor development, and then was investigated because of unilateral pronounced trapezius muscle. And now he was brought because of scoliosis. He was referred by rheumatology department at the age of 16, very, very late. And because of pain in his hips, he was treated for 10 years in the rheumatology department without knowing what is this. So his brother also was investigated, both of them normal phenotype and normal intelligence. So when we started to understand the torticollis through a 3D reformatted CT scan, we found there is 16 years old and the persistence of the cartilaginous state of the spine, which is abnormal. Because after the age of 5, 6, 7, it should be all ossified. When we did the reconstruction CT scan, we found there is C1, C2 dislocation. So the child lived in puberty and lived in a very dangerous life because never diagnosed before. We diagnosed this at the age of 16. So luckily, he passed without any lethal complications. C1, C2 dislocation is a lethal complication. As you see here, his scoliosis is massive. And as you see, the phenotype of the spine is cartilaginous, is not well formed. The same, we see coxavarant. This is not genuine coxavarant. This is secondary because of defective ossification. As we have defective ossification of the spine, we have defective ossification of the pelvis. And as you see that the femoral neck very weak, osteopenic, not osteoporotic, but osteopenic, and there is massive ossification of the ischial as you see. Family history. His younger male still have problems in his back, pain in his back. As you see, is totally normal school, normal intelligence. Schooling performance is good, but the discrete lumbar scoliosis. We found platyspondylitis, which adds to our potential for diagnosing this case. The lower lumbar vertebra, the lumbar vertebra, lumbar spine is the foundation of the body. Very important when we have patients, adult or kid, we should, with lower back pain, the first thing to do is radiography, not MRI. Because the MRI can never give me the configuration of the bone and the consistency of the bone, never. This is misleading. Sometimes I have patients coming from different parts, bringing to me MRI for their bone problems. I reject, because MRI specialized for the soft tissue, not for the solid tissue. But this is now a model. Yeah. The CT scan of the child with early onset back pain, there is defective ossification of the scleromy, but of minimum involvement, not like his older sibling. Very mild coxa valga. This is the mother. The mother with apparent ischio pelvis ossification. And for the last 10 years, she says she is young. She had problems in her back as well. So now we investigated the mother and the father as well, because both of them have problems in their lower spine. As you see, there is osteoarthritis in the mother, and there is spondylolisthesis in the father. Both of them are of normal stature. All the family have normal craniofacial contour. There is no dysmorphic clinical features of whatsoever, which made the rheumatology department exclude any syndromic or heritable bone disorder. So, to complete our work, we extracted the blood from these patients and sent it to my colleague, Professor Superti in Basel, and he made the genetic testing clinically. It was made epithelial dysplasia. Very severe type in the proband with minimal or also other involvement in the sibling and his parents. And this is the gene that was discovered. And we did genetic counseling for the family, and we explored other family subjects, cousins, because this is autosomal recessive. Cousins, in autosomal recessive, not necessarily to be 25%. Sometimes all the family subjects, all the siblings are, offsprings are affected. So don't follow the classical. You do your job by yourself. Textbooks give you the idea, and you ameliorate your knowledge. Here I put another patient, again. When we have cartilaginous state, persistence of the cartilaginous state of the vertebra of the spine, we have lots of other examples in syndrome, about 70 syndromic entities in which there is the persistence of the cartilaginous state of the spine is really challenging, because cannot be corrected. It's the other patient to my right side is a girl diagnosed with cleidocranial dysplasia. We have two patients, few months old, and adult patient, both with cleidocranial dysplasia. When we diagnose the case early on, not late, you are helping the family, helping the child for proper management, and helping other family subjects because in heritable bone disorders we have discrete malformations in other subjects which require to be securitized, not neglected. So we are not working piece by piece. Me and my colleagues, whether in Tunisia, in Austria, in St. Petersburg, in Ilizarov, we don't work piece by piece. We take a patient as a whole, cleft foot as a whole. Happened several times that when I have patients in Austria gets corrected for with Ponseti for cleft foot, and the same patient came to me after 2 years for spine problem. I phoned my colleague. You did Ponseti for this baby, for this child. Do you know what does he have in his spine? He said, no, this is not my specialty. I'm just verkauft. Ich bin Fußspezialist. We are not carpenters. We're supposed to be medical doctors. Carpenters, yes, they fix the leg of a table because it is not a multi-system system, not interrelated or multi-system human being. This is table, but in human beings, especially in long-term malformations, we should be much more accurate. Other disorders of torticollis in female growth, which is Merck's association. This can be diagnosed as early as the first few months of life. Merck's association is patients have a combination of uterine aplasia, hyperplasia, renal agenesis, ectopy, abnormal cervical, or upper thoracic vertebra. That's what called previously as Rokitansky syndrome, but Rokitansky syndrome without spine malformation complex. 3 different and unrelated girls present congenital torticollis associated with cervical kyphosis. This is the first child, 12 years old, girl, with malsegmentation of the spine and have with cervical kyphosis. Cervical kyphosis was because of homovertebral bone undiagnosed. In the X-ray, it was evident there is homovertebral bone and there is malsegmentation, but not like the CT scan as we see here. It's much more realistic. As you see, the 7th cervical, the attachment with fibrotic tissue to homovertebral bone. Of course, she underwent operation and this was excised, but she has another problems, major problems. This is the reconstruction CT scan, as you see in other patient. 2 homovertebral bones. Without reconstruction, without 3D reconstruction, you can never diagnose this. Never. I have an Australian patient she lives in America, and she brought her daughter, she is Australian, similar problem. They did for her MRI. Nothing evident in the MRI. And the CT, the normal radiology was about puzzle. Because of the anatomical overlap, you cannot see it. You need to delineate and localize the problem. This is for proper management. When you have strong belief in medicine, This is another child, few months old, with torticollis. As you see, there is an inclination of the spine of the head to one part. When we did CT scan, this is Austrian. Okay, we see that the malformation started from the craniocervical C1, and this is the odontoid here. C1 is not fully formed. The posterior ring of the C1 is not there. It's aplasia, or there was assimilation of the posterior arch. This is the CT scan. She was, I think, 6 months or 7 months. As we see, there is a puzzle, and we used in orthopedic hospital of Speising, when we have such problems, we send it to Basel for spine surgery. But I said, before we send it there, we should check her kidneys and her genital system. But we found in the kidneys, this is another photo, and the kidneys, there's gross malformation of the kidney. Cake-like kidney, it's fused kidneys. There was no ovaries, no uterus, and a plastic vagina. So, diagnosis straightforward, Merck's association. Yeah, it's sad when some patients reach the age of 12, 14 years and they carry their files with them, but the diagnosis is idiopathic. It's a real threat to medicine, actually. And I wrote many papers about idiopathic because I received patients with idiopathic and we give them diagnosis right away. And then we have 2 other siblings, cousins. By the way, when we are talking about autosomal recessive, doesn't mean consanguinity. Because you have in Austria and Germany and Czech Republic as well, families in agricultural areas, they live there for generations. So here in one land, a family, adjacent neighbor, another family, another. So they have their bars, they have their restaurants, and they mixed up by time. After 2, 3 generations, they became relatives because the same environmental factors can affect the genetic potential and can be. So most of my patients in Austria, autosomal recessive. In Deutschland, autosomal recessive. In Czech Republic, autosomal recessive. It's very rare autosomal dominant, actually. So it's not only in the third world of cousins or something like this. Yeah. So as I introduced before, Merck's association is not uncommon because mostly these patients with spine malformation complex are referred to spine surgeons, and spine surgeons, pediatric spine surgeons, never pay attention that there is something called Merck's. So you have to check first the genital system, the kidneys, the heart, because it's all included in the embryogenesis process. Another girl, she was operated because of lipoma in her spinal lipoma in her early age, and she was treated for esophageal atresia, rectal stenosis, and later on, this is her MRI for lipoma. At the age of 4, she was removed. Later on, at the age of 9, she came to the hospital with torticollis. Nobody understood what is this. It's not congenital torticollis. So what is this? So it's very interesting because when we did the X-rays, we didn't understand anything. Yes, there's torticollis, but because of the anatomical overlap of the craniocervical, it did not delineate what is the problem. So we refer to this is the gill, as you see, the torticollis, Bennett's phase of limited value. So refer to detailed CT scan. As you see here, that was the first impression in the reformatted CT scan that we have a problem in the craniocervical region, and specifically clivus C1, C2, diffuse fusion between the clivus C1 and C2. This is wonderful. We approach the definite diagnosis of a 13-year-old child of torticollis, progressive torticollis, because this is correlated with the growth, with longitudinal growth of the spine, and this is very, very serious. So we have the clivus, and this is the posterior part, the posterior wing of C1 of the atlas. Never diagnosed before, and some of the colleagues suggested in the beginning to start with Botox or something like this. Yeah, of course, it's untrue. When we did other CT scan, we found there is another problems of multi-segmentation. So it's all Vata. We have MERS, we have Vata association. Acronym used to describe vertebral defect, anal atresia, stenosis, esophageal atresia, and radial defects. Yeah. This child, 11 years old, with torticollis, with poor schooling achievement, developmental abnormalities, and his torticollis was progressive with age. So this is very unusual that we found diffuse fusion of clivus C2, C1, C2 in the reconstruction CT scan, as well as in the sagittal 3D. It's one bulk between clivus C1, C2. Unusual, extremely unusual. When I exposed this child and his family, siblings and parents, to my colleagues in Singapore, and they are geneticists, laboratory oriented, they say, Ali, we have another children like this, about 8 children like this from different parts of the world. So they sent me the documentation, the X-rays and the CT scan, and I gave reports of every child, and then we started to do the genetic testing. And then we conclude that this is resulted in CDK10 mutation. And we tried to publish it. And then the referees in American Journal of Human Genetics said, okay, it's nice, but show this to us by examining the mouse, the mutated mouse, and compared to the normal mouse with mutated the CDK10. And then the colleagues in Singapore Star Center, they sent to me mutated mouse about 6 and normal mouse 6, and we did CT scan. It's not here. Maybe next time I can bring it to you. It's published. Anyhow, we found exactly what we have in C1, C2 of malformation, we found in the mutated mouse. And we found it also in the ribs. So I did the documentation of the mouse, malformed mouse, mutated gene, and compared to the mutated human being. It was compatible and was accepted in 24 hours. Unprecedented, because the results were breakthrough in medicine. So this is the conclusion. As I said before, we cannot work in medicine piece by piece, because piece by piece in human beings is we are laughing on ourselves. Medicine can never be a merchandise. Medicine should be a message. I believe in it strongly, and my colleagues as well, because this is our message in life. When we start to choose medicine as our target to serving people, in my lifetime, I documented 6,000 patients. 6,000. In Australia, I published 230 because of the patients, undiagnosed. They came to me undiagnosed. We diagnosed in our specialized clinic in orthopedic hospital of Speising. So we have the privilege to publish it after 90% when had the nomination of idiopathic. Can you imagine a child of 14 or 15 years old and two other siblings, another story, living his life and parents with idiopathic? This is unfair. No justice in this. Thank you so much.